Good morning. First, I would like to thank the organizing committee and Professor Czarnecki personally for inviting me to this important regional expert meeting. My name is Atanaska Elenkova, and I'm the head of the specialized clinic for pituitary, adrenal, and gonadal diseases, which is part of the Department of Endocrinology of the Medical University Sofia in Bulgaria. We've been working in a close collaboration for many years with other specialists from two other university hospitals in Bulgaria. We work with experienced neurosurgeons in transsphenoidal neurosurgery, with specialists of MRI and CT diagnostics, specialists from the Department of Radiotherapy, from the University Hospital St. Ivan Rilsky. You can see, and also with pediatric endocrinologists from the University Pediatric Hospital in Sofia, Bulgaria. And as a result of this close collaboration, in 2016, we created a joint expert center, which was certified by the Bulgarian Ministry of Health as a national center for rare endocrine diseases. And 2 months later, in July 2016, our expert center was approved as a full member of the European Network on Rare Endocrine Conditions, ENDORN. We take part in two main thematic groups, MTG4, which is dedicated to genetic endocrine tumor syndromes, and MTG6, which is hypothalamic and pituitary conditions. So more than 15 years ago, we decided to create a database of all medical records of our patients with pituitary and adrenal tumors, and it was a very enthusiastic idea. So we invited our colleagues, endocrinologists from the 6 specialized university hospitals in endocrinology, which are affiliated to the 5 medical universities in Bulgaria. They sent us the documentation of their patients with pituitary and adrenal tumors, and we created this database. And in 2010, we decided to perform the first analysis of our data. So you see that Bulgarian acromegaly database is part of this huge registry. And in 2010, we already have 742 patients with acromegaly, and more than 90% of these patients are referred, diagnosed, treated, and followed up in our expert center. You can see the female predominance in our cohort. 63% are women versus 37% of men. And it's interesting because most of the registries report a slight male predominance. Similar data were reported by the Spanish registry, and particularly for the Basque region. They reported 65% of women among their patients with acromegaly. The prevalence of acromegaly in Bulgaria was estimated to 48 cases per million. The incidence is approximately 2 cases per million per year. This data correspond well to the data from the literature. The mean age diagnosis was about 43 years and didn't differ between sexes. So let's focus on the main topic of my presentation, this mortality in patients with acromegaly. All we know that all published nationwide studies have shown an increased mortality, 2 to 3-fold increased compared to the general population. Cardiovascular, respiratory, cerebrovascular diseases, and malignant diseases are the leading causes, as main independent predictors are considered active disease, delayed diagnosis, older age diagnosis, female sex, radiotherapy, and especially conventional radiotherapy, and hypopituitarism, and particularly uncontrolled ACTH deficiency. Therefore, the timely diagnosis and optimal control of growth hormone and IGF-1 levels are mandatory to ensure normal life expectancy in our patients with acromegaly. all studies published in the last 2 decades in the era of modern therapy have shown that long-term postoperative treatment with somatostatin analogs and pegvisomant improve life expectancy in patients with active acromegaly after unsuccessful neurosurgery. Let me draw your attention to the results of the Acro study analysis, this huge retrospective cohort analysis of more than 2,000 patients with acromegaly treated with pegvisomant with a median follow-up of approximately 4 years. Higher on treatment IGF-1 levels, older age, and longer duration of acromegaly before starting treatment with pegvisomant were considered and were associated with higher all-cause mortality rates. Now I'm going to present you briefly the results of 2-hour studies focused on mortality in patients with acromegaly. The first one was a retrospective comparative cohort study investigating the impact of different treatment modalities on disease control and mortality in patients with acromegaly, and we compared 2 cohorts. Bulgarian patients with acromegaly, 407 patients, and 220 patients, residents of Campania region in Italy. And what was the rationale for such a comparative analysis? The similarities. Bulgaria and Campania region of Italy have comparable populations. Both departments of endocrinology in Sofia and Naples are national referral centers for acromegaly, and both centers have acromegaly databases. But what was the huge difference? In Italy, somatostatin analogs were available since 1988, and pegvisomant was introduced in 2004. In Bulgaria, at that time, none of our patients had access to these modern therapies. This is because of funding restrictions. So although octreotide LAR was registered in Bulgaria in 2000, it was fully reimbursed at the end of 2008, pegvisomant in 2010, and pasireotide LAR in 2012. So we hypothesized that patients with acromegaly in Bulgaria may show higher mortality rates compared to Italian patients due to lack of access to these modern therapies. This table summarizes the main patient's characteristics, and you can see again the female predominance in Bulgarian cohort. Both cohorts didn't differ significantly with respect to their mean age on diagnosis, mean follow-up, percentages of macroadenomas, but you can see that Bulgarian cohort had higher median baseline and final IGF-1 levels, final growth hormone levels, and the most important, higher number of deceased patients. Regarding the comorbidities and complications, we observed higher proportions of patients with hypertension and hypogonadism and panhypopituitarism in our cohort compared to the Italian cohort. And regarding the treatment options, only 32 Bulgarian patients were treated with somatostatin analogs. It was in a clinical trial for a very short period of time, and none of these patients was under such treatment by the end of the study. None of Bulgarian patients were treated with pegvisomant at that time. The other thing, a very important thing, is that the use of conventional radiotherapy in Bulgaria was high during the investigated period of time. In contrast, in the Italian cohort, the use of radiotherapy decreased after the introduction of somatostatin analogs in clinical practice. We evaluated the mortality in both centers in a 10-year period of time between the beginning of 1999 and 2008. The life or death status was assessed based on the data that we obtained for the civil registration and administrative services of both countries. The control of acromegaly was defined according to the current guidelines. As basal growth hormone levels of less than 2.5 nanograms per milliliter, growth hormone levels of less than 1 nanogram per milliliter during the suppression of GTT, and normal age and sex-adjusted IGF-1 levels. As the main indicator for mortality, we used standardized mortality ratio, which was calculated by the well-known formula by dividing the total number of observed deaths by the total number of expected deaths. And these are the most important results. Biochemical control of acromegaly was achieved in 39% of Bulgarian patients compared to 50% of Italian patients. Bulgarian patients had 2 times higher mortality rates compared with the general population, SMR of 2.0 compared to SMR of 2.66 in Italian cohort, which means that the estimated mortality in Italian cohort was similar to that of the general population. However, the mean age of death in both cohorts was comparable. It was about 61 years. Cardiovascular events were the leading causes of death in both cohorts. Malignancies are in the second position for the Campania cohort, but they were displaced by the cerebrovascular events in our cohort, and it could be explained by the higher use of radiotherapy, of conventional radiotherapy during this period of time. In this table, you can see very, very clearly that the all-cause cardiovascular and cerebrovascular mortality are significantly higher compared to general population in our cohort, with the predominance of cerebrovascular mortality in irradiated patients and cardiovascular in non-irradiated patients. Regarding the patients in remission, we observed a normalized all-cause mortality, cardiovascular mortality, but you can see that cerebrovascular mortality remained higher, and especially in patients who underwent radiotherapy. Factors predicting mortality in the Bulgarian cohort in univariate sex and age-adjusted Cox regression analysis are considered to be the age at diagnosis and the last growth hormone and IGF-1 levels, as well as hypertension, diabetes, dyslipidemia, and loss to follow status. And when these variables were applied in a multivariate Cox regression analysis as independent predictors of mortality, are considered age at diagnosis and growth hormone levels. IGF-1 levels were not included in this analysis just because only small proportion of diseased patients had available values of this parameter, only 14 patients. We observed a trend for a higher rate of deaths in patients after unsuccessful transperineal surgery, but without reaching statistical significance, and the Cox model didn't show significant influence of surgical outcome on mortality. After age adjustment, neither partial nor panhypopituitarism were associated with higher hazard ratios. We concluded, based on the results of our old study, that the activity of acromegaly was demonstrated to be the major predictor of mortality. The use of conventional radiotherapy increases the cerebrovascular death rates. The use of somatostatin analogs and pegvisomant leading to a stable remission could increase the life expectancy in patients with acromegaly. But the influence of comorbidities of uncontrolled arterial hypertension, diabetes, dyslipidemia should also be taken into consideration regarding the mortality in these patients. So 16 years later, in 2024, we are happy. We have already fully reimbursed somatostatin analogs and growth hormone receptor antagonist pegvisomant. All these medications are prescribed by a specialized commission at the Expert Center for Rare Endocrine Diseases, and protocols are approved by the National Health Fund. So we decided to conduct a new retrospective study, which aim was to reevaluate the mortality of Bulgarian patients with acromegaly after reimbursement of these medications, and we included 537 patients with acromegaly from our database. Again, 73% are women, 37% are men, 83% underwent transphenoidal surgery. Information for the patient's life status was obtained from the National Statistical Institute, and we decided to evaluate again a 10-year period of time in order to compare our results with the old study. And we selected this period from the beginning of 2010 to the end of 2019. We didn't select the last decade in order to avoid the negative impact of COVID-19 pandemic on mortality data. And mortality was evaluated again by using SMR. I'm going to present you preliminary data. We have a lot of statistical analysis to do, but I think that it's clear in this table, which compares the group of diseased patients with the live patients. You can see that in the group of diseased patients, patients with active disease predominant and patients who underwent radiotherapy. And in other group of live patients, there is a huge predominance of patients in remission and medically treated, but not with dopamine agonists. You can see that both groups are comparable. So we know that dopamine agonists have very low efficacy in patients with acromegaly. It's not surprising, but patients on monotherapy with somatostatin analogs, patients on double combinations, different double combinations, on triple combinations, with somatostatin analogs and pegvisomant or dopamine agonists are significantly higher proportions in this group. And the most important result, the SMR of our new study is 0.65, quite similar to this one of the companion patients of our old comparative study. So the mortality rate in Bulgarian patients with acromegaly restored to the levels of the general population, and the mean age of death is increased by 7 years. It's very, very important thing. Malignant diseases, cerebrovascular and cardiovascular diseases are again the most common causes of death, but when we made separate analysis, when we separately evaluated SMRs for each category of the disease, we can see that malignant diseases have very high SMR, but cardiovascular and cerebrovascular mortality restored to the normal values. Lung cancer, colorectal, and breast cancer are the most common cancers in our cohort. Because looking at this data, we can't help but wonder if it is an effect of the growth hormone oversecretion or just follows the general global trend. And we see that the most common cancers in our cohort of patients with acromegaly are the most common cancers worldwide. This is according to the global cancer statistics of the World Health Organization for 2022. Lung cancer, breast, and colorectal cancer. So we can conclude that mortality rate in Bulgarian patients with acromegaly significantly improved after introduction and reimbursement of somatostatin analogs and pegvisomant. In the routine clinical practice, that cardiovascular and cerebrovascular mortality restored to the expected levels of the general population. Improved life expectancy of acromegaly patients is a result of optimized medical care and reimbursement of the contemporary pharmacological treatment. But high mortality associated with malignant diseases remains, and it seems to follow the global world trend. And let's look at the data of the recently published studies. This is a cross-sectional population-based study based on the UK Acromegaly registry. The study population is more than 3,000 patients with acromegaly, and faster remission time, surgical intervention, and treatment with somatostatin analogs are associated with improved survival outcomes. These are the data from the Danish registry, and data are analyzed across 3 decades according to the year of diagnosis or treatment initiation. The study focus was on treatment modalities, biochemical outcome and comorbidities, and a special focus on cancer and mortality. And the researchers have concluded that modern medical treatment regimens improve diagnostics for comorbidities, lead to better disease control, to lower frequency of severe hypopituitarism, to decrease mortality rates, but the risk of cancer remained unchanged. And last, I would like to show you data of one recent meta-analysis which included 19 observational studies. And the overall incidence of cancer here presented a standardized incidence ratio is 1.45, and you can see that cancers that are associated with acromegaly are thyroid, brain, connective tissue cancer, gastric, urinary system, pancreatic, hematologic, but not the most common cancers. Sorry. Lung cancer, breast, prostate, there was no association with growth hormone oversecretion. So what we have learned of this, of the literature data, of our own experience, of our projects, that the stable biochemical control is crucial for the outcome of our patients with acromegaly. Long-term treatment with somatostatin analogs and growth hormone receptor antagonist pegvisomant can restore the all-cause and cardiovascular mortality. Radiotherapy, even modern stereotactic radiotherapy and radiosurgery, should be considered as a third-line therapy after transphenoidal surgery and after medical treatment. Management of comorbidities, diabetes mellitus, hypertension, dyslipidemia in our patients with acromegaly should not be left out of the focus of the physicians. Cancer risk, although not completely elucidated, should not be neglected in these patients, and they should be regularly monitored for the most common malignancies in the general population. And last but not least, patients with this rare pathology with acromegaly should be diagnosed, treated, and followed up in specialized expert centers by multidisciplinary teams, by experienced specialists. I think we all share this opinion. Thank you for your attention.